potentially one of the more controversial questions is frequency of treatment. The body's healing and regenerative response is traditionally broken down into 5 subcategories. The initial trauma, we have hemorrhage, blood rushes through. Hemostasis, blood seals off. And then we move into our traditional phases of inflammation, proliferation, maturation. Each part of these processes, each stage, has a very set time period. So you either work in with that time period to maximize your benefit, or you work against it and you're going to see complications. And these complications will be more than just post-inflammatory hyperpigmentation and more than just trying to activate more scar tissue. So let's discuss inflammation. Inflammation is characterized in Latin by 5 terms: dolor, calor, rubor, tumor, functio laesa. Pain, heat, redness, swelling, loss of function. What characterizes the inflammatory response is there's a microtrauma. You don't physically need to draw blood, but it still activates its healing and regenerative cascade as part of a controlled but resolved inflammatory response. As part of this, 2 key areas of consideration. Firstly, chemotaxis. Just as the Latin sounds, it's movements of chemicals from one area of the skin to another in an Uber or a taxi. We also consider phagocytosis. So neutrophils or phagocytic cells begin to adhere and stick to the vascular wall. They begin to roll, and then the vascular wall becomes permeable, so the white blood cells can make their way up and out, processing and digesting pathogens, kickstarting the wound healing response. As part of this cascade, we see the release of regulatory growth factors. These are the reason why your DP4 procedure works. These are the reason why your DP4 procedure is a predictable, reliable, safe, and evidence-based regenerative medicine. We could talk about a couple of 100,000 growth factors, but I want to highlight 7 that you need to know. The big boss of all things epidermis, no surprise, is called epidermal growth factor. The big boss of all things keratinization is keratinocyte growth factor. But keratinocyte growth factor is also the amplifier, the shouter, the town crier that directly communicates with the fibroblast to send messages. What we also see is the release of melanocyte growth factor to determine if there's too much pigment or not enough. The big boss of all things dermis and hypodermis is a larger family of growth factors called transforming growth factors. What manages fibroblast production and the production of collagen, its form, its type, its placement, its transition, no surprise, is called fibroblast growth factor. And what manages angiogenesis, the growth and development of new capillary networks, is the combination of vascular endothelial and platelet-derived growth factors. These will also work with vasodilation, vasoconstriction, placement of the vessels. So with all of these, we understand why our DP4 procedure can work for such an array of indications, why a regenerative procedure is able to promote rejuvenation, regeneration, and repair. The inflammatory response is broken into 2 subphases. We have acute inflammation, fixed, but also we have chronic inflammation. Biologically, this is resolved in a 10 to a 14-day time period, 2 weeks. So under normal circumstances, biologically, if we have full resolution of the inflammatory response in a 2-week time period, then this dictates that for all of your superficial epidermal procedures, no blood, you are going to treat these as often and as frequently as every 2 weeks. What happens if your patient can't commit or afford that? No problem. We can stretch out to every 3, we can stretch out to every 4. However, note though, after that 2-week time period, your growth factor, your release, your regenerative agents are going to begin to plateau and then reduce. So 2 weeks is always better than 4. With this, if you see blood, reduce your needle depth. So now this creates an uncorrupted and uninfluenced, effective and resolved inflammatory healing response. The second part of consideration for wound healing is the proliferative response. And this is where we see collagen production come through. Although scar tissue has a very bad reputation in aesthetics, I'm going to give you another thought process and a different approach to scar tissue. Imagine I'm a caveman. And then I get attacked by a dinosaur. Work with me. If I have a big gash down my chest and shoulder here, in caveman times, there's no pharmacy, there's no hospital, there's no doctor, there's no nurse, there's no bandages, there's no antibiotics. So what's a caveman going to do so I don't die by the afternoon? Scar tissue. So irrelevant of what your Fitzpatrick skin type, irrelevant of your ethnicity, we all have the risk anthropologically to produce cicatricial healing. So cicatrice comes from the Latin for upside down. So what we see here is collagen in places that it's not supposed to be. So as part of a rapid healing response, the body uses mature, thickened type 1 collagen to try and re-epithelialize as quick as possible. Cicatricial healing is where we see the overgrowth and the overpositioning of collagen. Note that there's collagen in the epidermis. There should be no collagen in the epidermis. What fuels this is trauma. Heat, ablation, multiple wound healing responses. The physical profibrotic growth factors which encourage this healing are called transforming growth factor beta 1, transforming growth factor beta 2, and heat shock protein 47. When these get released as part of trauma, burning, multiple wound healing responses, ablation, then they will contribute to scar tissue, but also an imbalance of melanocyte growth factor, leading into post-inflammatory hyper or post-inflammatory hypopigmentation. With your DP4, there is no heat. There is no ablation. So what we instigate is very similar to what we call the embryonic wound healing model, which is called scarless wound healing. How this is characterized, firstly, is through the puncture channels, the positioning and stimulation of immature type 3 collagen. And then we see more superficially the role of epithelial cells to re-epithelialize and to close up. Pros and cons. Well, you do have the right cell in the right position, but we also understand that type 3 collagen is immature. It's weak. It's a lot like a little goldfish. So it's not got durability and strength. However, over a 6 to an 8 week time period for the average adult, we now see the transition, development, and metamorphosis of the immature type 3 collagen into the durable type 1 collagen. By contrast to cicatricial healing, you now have type 1 collagen in the right position, and then more superficially, the role of your epithelial cells. Because this process takes 6 to 8 weeks for an adult, this now dictates that for all of your blood procedures, you should treat ideally every 6 to every 8 weeks. No sooner, otherwise you will risk multiple wound healing responses. No later, because you will miss reactivating the collagen and reactivation of the remodeling phase. The proliferative response then leads us on to the maturative response. And this can continue the regeneration, the remodeling, the healing and repair for up to 2 years. So your best results for your DP4 are not when you rush to the mirror tomorrow. Your best results for your DP4 are not when you run to the mirror in 2 weeks' time. It starts laying down the foundations at week 3, at week 4, and continues on the healing, the remodeling, the repair, the rejuvenation, anywhere up to 2 years after one procedure. We now understand that by treating more superficially, we open up a whole new area of indications that you never knew possible with your DP4. Acne, milia, hyperpigmentation, hypopigmentation. We understand by treating more superficially, you can see your patient as frequently as every 2 weeks. So this becomes profitable. As a regenerative medicine procedure, we understand also that this is fundamental for skin health, skin quality, integrity, and functionality, but also the average patient experiences just 24 hours to 36 of a mild to a moderate sunburn in appearance and sensation that can easily be disguised with a tinted sunscreen camouflage and applied post-operatively. It is possible to create procedural programs. For example, patient comes in with very, very deep wrinkles, but also hyperpigmentation. Wrinkles are here, hyperpigmentation's here. For your hyperpigmented conditions, you are going to treat within this area every 2 to every 4 weeks. However, for your dermis and for your hypodermis, you're going to treat these under normal circumstances every 6 to every 8 weeks. So with this process, if you have a patient that presents with both, it's possible for you to alternate your treatment depths as part of a treatment program. For example, for an 8-week program, you could treat with blood, first procedure, pigment and wrinkles, and then 4 weeks later go in more superficially to treat the hyperpigmentation. 4 weeks later, blood. 4 weeks later, no blood. But you could also see your patient as frequently as every 2 to 4 weeks. So you could go first procedure, blood. 2 weeks, no blood. 2 weeks, no blood. 2 weeks, no blood. 2 weeks, blood. So you're not drawing blood more frequently than every 6 to every 8 weeks. You're not treating your inflammatory response more frequently than every 2 weeks. So now you're creating control, but manipulating your treatment program to maximize all of your biological responses.